Hello and welcome to this VJ Hemonc podcast. This podcast is part of the acute myeloid leukemia channel on VJ Hemonc, which is supported with funding from BMS and through an educational grant from Jazz Pharmaceuticals. These supporters have no influence over the production of the content. This podcast is intended for healthcare professionals only. In this episode, we explore how advances in molecular profiling, measurable residual disease assessment, targeted therapies, and transplantation are transforming the management of AML. As our understanding of AML biology continues to deepen, treatment decisions are increasingly guided by genomic alterations and disease monitoring strategies. At the same time, novel targeted therapies are reshaping treatment pathways and raising important questions about how best to integrate transplantation and maintenance approaches. So, let's get started. We begin with one of the most active areas of development in AML, menin inhibition. Amer Zeidan discusses findings from the KMT2A-007 study evaluating ziftomenib in combination with intensive chemotherapy in patients with newly diagnosed NPM1-mutated or KMT2A-rearranged AML.
I had the pleasure of presenting the data from the KMT-07 looking at the addition of ziftomenib to 7+3 in a phase 1 trial, large phase 1 trial that used ziftomenib in a dose escalation fashion in combination with 7+3 in patients who were fit to receive intensive chemo and had NPM1 or KMT2A-rearranged leukemia. And what we have seen in this trial is that the combination was actually safe. So the early mortality, the induction mortality was only 2%. Most of those patients were able to tolerate the therapy without significant grade 3 toxicities. Most of the toxicities that were seen were a reflection of the myelosuppression that we generally see with 7+3. So we did not see evidence of additional myelosuppressive complications. We also saw a very low incidence of grade 3 or higher differentiation syndrome or QTc prolongation, which are toxicities that we look for when we use menin inhibitors. But what was, I think, most interesting is the efficacy. We saw very nice early efficacy early on and subsequently in this longer follow-up from the study. So the 12-month survival in the NPM1 cohort was 94%. The median survival was not reached. The CR rate was also in the range of 94%. So all of these numbers, I think, are very encouraging, very high rate of MRD negativity. And importantly, the time for count recovery was also in line of 7+3, around 28 days. So I think these data suggest that the combination is safe, is tolerable, and has very kind of good evidence for efficacy. And based on these results, we have an ongoing phase 3 trial called the KMT-017, which is exploring 7+3 plus minus ziftomenib, as well as a separate trial within the same protocol that's looking at aza-ven plus minus ziftomenib. And hopefully those randomized trials will provide the confirmation for the results we just saw in the phase 1 trial.
These findings highlight the potential of menin inhibitors to move beyond the relapse and refractory setting and become part of frontline AML treatment strategies. As more menin inhibitors enter clinical development, understanding how these agents differ in terms of efficacy, tolerability, and convenience is becoming increasingly important. Amir Fathi discusses key differences among menin inhibitors currently approved or under investigation for AML.
It's hard to know. I mean, I think some of the menin inhibitors are farther along. Some are still in clinical trials and additional numbers of patients are being treated. So it is difficult to know whether truly the rates of composite remission or CR plus CRh or CR are going to be that different from another. They may be, but time will tell. There are some differences in sort of the tolerability profiles of the different menin inhibitors. Revumenib, for example, is associated with QT prolongation. Ziftomenib has a signal for itching. There is differences in dosing and schedule. Revumenib has different doses for concomitant use of CYP3A agents. It is twice daily, whereas ziftomenib is once daily. The other drugs that are being developed also have their unique features. There is a class effect with differentiation syndrome that seems to be similar across the various different types of menin inhibitors. I think as we get more of these in play, probably the most likely thing to impact the differentiation between these is efficacy or activity, if there is indeed a difference in activity, followed by convenience for patients and tolerability.
Alongside menin inhibition, FLT3 targeted therapy remains a central part of precision medicine in AML. Robert Negrin reviews key considerations when selecting among available FLT3 inhibitors, including efficacy, toxicity, clinical experience, and access.
Yes, clearly the introduction of knowledge about different mutations in AML has made a major impact on how we take care of patients, with FLT3 mutations being critically important. We recognize that there's multiple different agents that can be used in treating these patients. And a lot of it comes down to personal choice and what available data we have. Unfortunately, there's not much randomized data comparing these different agents. So a lot of it has to do with toxicity concerns and what the available studies teach us. So we're really excited about the session here at the meeting, which will update us on the use of different inhibitors. And the more selective inhibitors seem to be those that are gaining more interest and gaining more traction, just because they appear to have fewer toxicities. And so that's often the major consideration: is in addition to the benefit, what are the toxicities? And of course, what are the costs of these agents? And they can vary from institution to institution. And also, of course, what is available in wherever you tend to practice. These are all different considerations that we use. In our practice, we tend to use more gilteritinib as the agent that we're most familiar with, and for which we tend to use in our particular environment, because it seems to be quite well tolerated and has excellent efficacy. But other agents are coming along, and we'll see how they fare.
Beyond response rates, understanding the real-world value of FLT3-directed therapy is becoming increasingly important. Jorge Cortes discusses findings from a quality-adjusted survival analysis evaluating quizartinib in newly diagnosed FLT3-ITD-positive AML.
This is a very interesting analysis that's called this Q-twist. That's a sort of an acronym that we use. And it's when you look at these randomized studies and there is a survival benefit of one drug versus the other, the question is, how much is that just, they live more or less than the other arm, driven by time that you spend with a lot of side effects in the hospital anyway, or how much of that survival benefit could be because of a rescue after a relapse? Because all of that is survival, but is it valuable? So this analysis focuses on the valuable time, the time that the patient has without side effects, and the patient that they have without need for additional therapies and other things. So when you look at that valuable time, we see that there is particular benefit for quizartinib, and mostly driven by the higher rate of responses and longer remission duration and so on. It's not so much from the safety point of view that there are actually some areas where there's a little bit more side effects, but because of the high rate of response and duration of remission and all of that, that valuable time becomes significantly better. So that emphasizes the value of the quizartinib combination with standard chemotherapy versus standard chemotherapy alone as something that really benefits the patients.
These data provide a patient-centered perspective on the value of targeted therapy, considering not only survival, but also time spent in remission without significant toxicity. As targeted therapies continue to improve disease control, they are also reshaping one of the most important questions in AML: how and when to use allogeneic stem cell transplantation. Arnon Nagler discusses how targeted therapies are being integrated before and after transplant, and why transplantation remains an important curative strategy in AML.
Yeah, so, transplant is the best, or used to be the only and the best immunotherapy that we have because of the attack of the donor immune cells against the patient tumor, so the so-called graft versus leukemia effect. And as for immunotherapy, we had the donor lymphocyte infusion. That was the first type of immunotherapy, so alloreactive cells. Yes, today immunotherapy is flourishing, and it's really nice to see it. Both adoptive cellular therapy, the CAR T-cell, chimeric antigen receptors, and the immunotherapy in ALL, myeloma, every disease we have, less so in myeloid malignancies like AML, myelodysplastic syndrome, and the myeloproliferative disorders. I would say that transplant is for myeloid malignancies is still, the only way to cure these diseases. For lymphatic malignancies, this may be questionable, although in lymphoma, there is almost no role for transplant in most of the lymphoma categories, let's say at least in B-cell lymphoma. T-cell lymphoma, is something else. And in myeloma, again, with the B-specific antibody, T-cell engager, CAR T-cells, the role of transplantation is becoming less, although we still, in myeloma, transplantation is still, upfront transplant results are better, but there is more and more data. For instance, you don't need to tandem transplant, and there are studies now that question the role of autologous transplantation. So, and also, transplant is not by its own. So the target therapy you can give pre-transplantation in order to get the patient to transplant in remission or with less tumor on board. And then in the transplant, you can give, light conditioning and not heavy conditioning. So for ALL, if the patient is MRD pre-transplant positive, we will give blinatumomab to get it in MRD. And this is just an example. And then you can give this targeted therapy post-transplantation in order either prophylactic or preventive to prevent relapse. So I would say that the transplant is still, in many patients, a curative therapy, and the targeted therapy, pre and post-transplant will even improve the results of transplantation. And I would say the transplant is here to stay, at least for myeloid malignancies.
As the role of transplant evolves, molecular profiling and MRD assessment are playing an increasingly important role in determining which patients are most likely to benefit. Arnon Nagler discusses how mutation status and MRD are informing transplant decision-making in modern AML care.
Yeah, so the field of AML is really moving, and the prognostication and the consultation of patients for transplant is based today on a mutation profile and the MRD. So at the beginning, the consultation and referring patient to transplant was based mainly on cytogenetics. But then when we have the mutation, we even change the classification of the AML according to LeukemiaNet 2022 for patients that received the intensive induction, and in 2024 for patients that receiving the non-intensive induction, so patients with venetoclax vidaza. So really the mutation profile is dissecting the AML, and the decision to go to transplant is based on the mutation profile. And moreover, MRD is a very important prognostic factor, and many studies have shown that patients that have a positive MRD pre-transplant doing worse. And so the combination of mutation and MRD really dictating the result of transplantation. And we should monitor MRD, and the MRD monitoring, according to a consensus paper that was published in Blood in 2026, is really, if to do it with peripheral blood or bone marrow, and the cutoff point and the technique is the flow or next generation sequencing is depend on the mutation. So the mutations that right now we have data that predicts relapse and the outcome is NPM1, but FLT3, the two-stage MRD of FLT3 by PCR and then next generation sequencing is coming in. And in the last year, there was discussion about is IDH1 or IDH2 is good for MRD monitoring, and IDH2 maybe yes. And the same we have with the KMT2A. So MRD and mutation dictate today the result of transplantation, and we are referring patient to transplant according to this. So the big issue is if a patient is MRD negative pre-transplant and favorable risk, should we maybe omit transplantation or the defer transplant. That this is in most of the cases are open question, but there is more and more data that in some categories, if the patient is MRD negative and especially sustained MRD negative, we may not need transplantation.
For those patients who proceed to transplant, the focus then shifts to maintaining remission and improving long-term outcomes. Robert Negrin discusses the growing role of FLT3 inhibitor maintenance following allogeneic stem cell transplantation.
Yes, so the use of FLT3 inhibitors following transplant is, in our practice, a standard approach based upon several different studies that show benefit for these patients that receive maintenance therapy, mainly, again, with gilteritinib. Some of the other agents are coming along as well. A lot of it has to do with toxicity concerns, how well these are tolerated. The duration of therapy is a controversial topic. In our practice, generally, we continue for 2 years following transplant, assuming that the patients tolerate these therapies. And we do monitor these patients with PCR-based assays looking for the mutation. And those that we find that are FLT3 negative, in some situations we may consider stopping early, mainly due to toxicity concerns. That's the major issue that our patients are facing.
Post-transplant strategies are also expanding beyond FLT3 inhibition, with other targeted agents now being explored in molecularly defined AML subgroups. Andrius Žučenka discusses findings evaluating ziftomenib maintenance following allogeneic stem cell transplantation in patients with KMT2A-rearranged or NPM1-mutated disease.
So we all know that revumenib is the first-in-class and the firstly approved menin inhibitor for relapsed/refractory KMT2A and NPM1-mutated acute leukemias. The AUGMENT-101 was a pivotal trial which used revumenib as a monotherapy for relapsed/refractory KMT2A and NPM1 patients. So our post-hoc analysis was mainly driven for understanding how patients were doing when revumenib was restarted after a consolidative transplant. So these were patients who were enrolled on the trial. They received revumenib, they achieved a response, and then went on a transplant and restarted revumenib. A total of 19 patients were enrolled with a median age of 39 years. So these were young patients. 14 of those were actually KMT2A-rearranged patients. So the majority of those were KMT2As, 4 patients with NPM1s, and 1 patient with NUP19 rearrangement. What did we see? That the median time from transplant to starting maintenance revumenib was 2 months. So this was quite an early intervention. It could be done from day 30 until day 180. So the median was 2 months, around day 65. The median duration of revumenib was 20 months. 3 patients are still on revumenib and have ongoing treatment. We were very happy to see that these highly pretreated patients, so half of them were already after the first allo, half of them were already post-venetoclax, and these heavily pretreated patients went on a transplant or started revumenib, and their median relapse-free survival at 12 months was 78%. So we only witnessed 4 relapses. So this is, again, very important. Of course, when we are speaking about post-transplant patients, we always fear about additional toxicity of any intervention we do. So for revumenib, the main concern which we witnessed was thrombocytopenia, which was quite prevalent in almost 50% of grade 3 or 4 platelet reduction from the baseline. But importantly, this did not lead to withdrawal of revumenib. It did require dose interruptions or dose reductions. And the majority of patients had their platelets going up after 3 or 4 cycles of revumenib. So we're very happy about these results. We did not see any differentiation syndrome. We only witnessed 1 grade 2 QTCF prolongations, which was not related to revumenib. So as for now, the signal seems to be good. The only concern we might see is the thrombocytopenia. But again, it could be managed, and these patients can be on revumenib for a prolonged period. And hopefully, this will further improve their overall survival and relapse-free survival.
Overall, the AML treatment landscape continues to evolve rapidly. From menin inhibition and FLT-directed therapy to MRD-guided treatment decisions and post-transplant maintenance approaches, clinicians now have an expanding range of tools to improve outcomes and personalized care. Continued research will help define how these strategies are best integrated across the patient journey and how they may further reshape the role of transplantation in AML. Thank you for listening. To explore more expert insights and interviews, visit the BJ Hem/Onc website. And don't forget to subscribe to our podcast for future episodes.